wearable technologies for the aging diabetics. So thank you very much for the invitation, especially Professor Diamanti, and good afternoon, everybody. I must admit I was very much perplexed when I saw the title, because it talks about aging diabetics and wearable technological devices. What do the elderly use? And they wear it and they carry it all the time. And so I decided to use the word aging as an evolving thing. People who are born, they are going to age. So I'm going to talk about wearable technological things in type 1 diabetics, and basically it's insulin pumps and the continuous glucose monitoring systems, and things that are useful for both type 1 and type 2. The CGMS is again here, and now we have this flash glucose monitoring technology that maybe is used more for type 2 than type 1, although it can be used for both. So I'm going to talk about insulin pumps and continuous glucose monitoring systems that are either real-time or they can be used as a retrospective information that they give. And I'm going to explain what it means. I don't know if people have experience with pumps at all and CGMS devices. Are there people who have used pumps in their... Have you seen people using pumps? Okay, there are a few. So I'm going to try and make things as simple as possible, and I'm going to give you the perspectives that we have now, because we hope that in the next decade we might finally come to the dream that all the diabetologists have, to close the loop and have the artificial pancreas. And we are kind of close there, but we still need some things. So the insulin pumps have come to our life for a few decades, and they have evolved. We have quite a few companies worldwide. In Greece, we have basically 2 companies. We try to mimic the physiologic insulin secretion. We know that there is always insulin in our blood. Even if we don't eat, we have to have some insulin in our blood so it can make our liver not produce glucose, because our liver is a factory that makes glucose, and if we don't have insulin, the liver overworks and makes too much glucose. That's why we have high blood glucose in the morning if we lack insulin, or if the insulin does not work in the liver, if we have fatty liver. So we should always have a basal insulin secretion, a basal insulin existence in our blood. That's the basal rate that we use. And every time we eat, normally our pancreas measures that the blood glucose goes up and secretes more insulin that it has already made. It is stored in the pancreas, and every time we eat, the pancreas sees that the blood glucose went up, and it secretes insulin. Insulin puts the glucose into the cells. Glucose goes down. Pancreas sees that glucose go down. It decreases the insulin secretion. So every time we eat, we have this pattern that glucose goes up, insulin goes up, and then they both go down. And so we're trying to mimic this, because this is the physiologic thing. Now, we have to admit that the way we use insulin now is wrong. We cannot ever make the same thing that the body does, because we do not inject insulin in the right place. We inject it subcutaneously, whereas insulin is produced in the pancreas, and it first goes into the portal system. So since we are not injecting in the portal system, we are starting wrong. But that's what we can do right now, and there are some trials to see if we can improve that. So the other thing that we have to know is that the basal rate is not flat. Our needs are not the same through the 24-hour period. Usually we have a little bit more need of insulin in the early morning because of the circadian rhythm that we have. So in the night when we sleep, this is 12 o'clock in the night, usually when we sleep in the night we need less insulin. In the early hours of around 6 o'clock, 6 to 8 o'clock, we need a little bit more insulin. Then our needs go down. There might be some increased need again a little bit in the early afternoon, and it goes down again. And with the insulin pens that we have, we can never achieve this, because we give our basal, this is the basal rate. We give our basal rate once every night, and so then we cannot control it. The insulin goes into our subcutaneous tissues, and then it goes into the blood on its own. We cannot control it. Whereas with the pump, we have the ability to decide and make these changes and ask the pump to give insulin hour by hour. So we can tell the pump to give at 12 o'clock in the night 0.4 units, for example, 1 to 2, 0.5, and then 0.6 and 0.8 and 1 unit. And so we have to find, the patient has to find his needs, and the pump gives you the ability to give the insulin differently every time. So if you find your needs, and in the morning you have a higher need, you can give a higher need in the morning. But with the pens, if you have whatever, Lantus or Tresiba or whatever, you give one dose and you say, I will give 20 units over the next 24 hours. You cannot decide that this time in the morning you will get more insulin or not. But with the pump, you have this advantage. And also, every time you eat, you can give an extra dose of insulin as with the pens. But we have some more advantages with the pumps that I'm going to talk about. So what is a pump? It is a device that contains insulin, and it has a battery that operates the pump, and the user decides how much insulin it's going to give. It's not something automatic. We program it to give the insulin, and we can decide how much insulin it will give every hour, and every time we eat, how much extra insulin it is going to give. The device is connected with the tube to the skin, and it is always connected, and it gives 24 hours a day, it gives insulin continuously. That's why it's called continuous subcutaneous insulin infusion. The advantage is that insulin is outside of the body. With the pens, we give the insulin, we store it inside, so we give 20 units of basal insulin. It is stored in the subcutaneous tissue inside the body. Here it is stored in the pump outside of the body. And we give small amounts every hour, and that leads to a better absorption of insulin. Because if you give a lot of insulin and you create a subcutaneous depot, then the absorption is not as good as when you give it in small amounts. So by giving insulin continuously in small amounts, you have a much better absorption. That's why you need less insulin. When you give a pump, you need less insulin than when you give it with an injection. That's one of the advantages of the pump. And you can carry the pump all the time. You can use it in different ways. If you want to show it or not, you can have a bath. You can disconnect it for a while. It's not a needle. The plastic tube stays under the skin, but you can have a bath for a while, and then you can connect the pump again. So what are the indications? Who are we going to think that we're going to use the pump for? People who go into a lot of episodes of diabetic ketoacidosis, people who are women who are pregnant, people who have a lot of hypoglycemias, especially in the night, and we cannot avoid them with the pens. People that have very few needs of insulin, like small kids or people with renal failure, that we have to give the insulin in very small amounts. If the patient, of course, wants it, because he needs to have more flexibility in his life. And people who have a very high insulin glucose levels that we cannot control with the pens. What I showed you earlier, when your needs are high, and by giving the basal insulin with the pen, you cannot actually arrange for this insulin to go into the blood during these early times. Of course, the pump does not work on its own. You have to have the user use it, so he has to have a motive, he has to have the intellectual capacity to use the pump. You have to have somebody who will follow him. It is not appropriate to just have the company follow the patient, that we unfortunately have seen in the past. You have to have a physician who knows about the insulin treatment with the pump and follow the patient. You have to have very regular follow-up and measurement of the blood glucose. The pump does not work on its own. And so actually you have to deal with your diabetes more frequently when you have a pump. It's not that the pump will give you insulin and you are done. You have to treat it at least at the level of treatment that we have now. As I said, hopefully the system is going to close and everything will be done automatically, hopefully in the next few years. So the pump has a lot of advantages, but you need to be able to understand what you do and how you do it. When you start the pump, you have to start with very basic things. You have to teach the basic rate first and simple boluses, how you inject in simple ways. The pump has a lot of advantages, advanced advantages, but you need to start simple first. You have to teach the family also in the basic things about diabetes. People who use the pump have to be educated in diabetes. And gradually, we are going to introduce more of the advanced features of the pump and see different basal rates and different ways of giving the boluses and how you can use the pump. The other thing we have to consider is the insulin, because the pump is a device and it uses insulin. And as I said, we start with the wrong way. We do not give insulin in the proper way. And the insulins we have are not perfect. The insulins we use need time to get absorbed. With the pump, they get absorbed more quickly than with the pens, but they're still not perfect. We have to consider not only the pharmacokinetics of the insulin, but the pharmacodynamic action of the insulin, how much the insulin works, not how much it is measured in the blood. So the insulin might be measured in the blood in this way, but its action might be prolonged. So we are interested in the action, basically, and that's what we have to consider when we give insulin. And this is something tricky that the patients sometimes do not think that I gave insulin a few hours ago and I'm going to give insulin again. They have to think maybe that there is some still acting insulin in the blood. And the pump helps very much in that, because it's a device you can program it to think and remember, whereas the patient might not remember. So to give you an example, we usually think that the prandial insulin lasts for usually 4 to 5 hours. So if somebody gives an injection now and measures his blood pressure 3 hours later and he sees it high, he might want to give another injection again. But after 3 hours, if he gave, for example, 10 units 3 hours ago, now you might still have a lot of the insulin that you gave before. And if you give another injection, you end up of stacking insulin, and then you end up of having a hypoglycemia, and you don't understand that insulin was added one dose over the other, and you came up with a higher dose than you predicted. So if you think that insulin lasts 4 hours, it's not actually correct, because you see that even with the rapid-acting insulin, you still have a 25% of insulin in the blood, and the regular even more. And if you think that insulin lasts only 3 hours, actually you have a lot of insulin. So in 3 hours, you might have about 45% of your dose. So if you measure your blood glucose 3 hours after an injection, you still have 40% of your previous injection. And you have sometimes to consider that, because if you add up the insulin doses one over the other, you might end up with having a hypoglycemic effect. And I will explain how the pump helps in that, and in the group session we will have later, we're going to have a practical example of how we use practically the insulin, the basal rate, and the boluses. Now this is an example of how much remaining insulin you have after 2 hours and 40 minutes. 50% of your previous insulin is still active. And so if you give insulin repeatedly, you have to consider that. Even 4 hours, 5 hours later, 12%. So it depends on how much insulin you gave and how much is on board still in your blood. Now, the pump has the best absorption rate. It's better than any insulin that you give. 27% is the intra-subject variability with detamine, 46% with glargine, and 60% with NPH. From day to day, from the same person, you might have a different absorption. With the pump, you have the best. It's not perfect, but it's the best that we can achieve right now. So this is a big advantage. And now, what also the pump helps is that it has a computer inside that thinks for you. Every time the diabetic person needs to inject insulin, he has to consider a few things. How much glucose do I have right now? How many carbohydrates I'm going to eat? how much insulin do I need to decrease my blood glucose, how much insulin do I need to burn these carbohydrates, what injection am I going to give, what exercise am I going to have, and what insulin is on board already. So all these things you have to do. I don't know if it's shown, but you have to do it every time you eat. You have to think and make calculations. Now the insulin, the pump has a bolus wizard that does all these calculations for you. What you only need to do is give the pump the information how much glucose do I have now and how much I'm going to eat. And then all the calculations every time are done automatically, so you don't need to think about them. The pump just gives you the suggested dose, and you can decide if you accept it or not. But all the calculations are done automatically. You don't need to calculate the same things every time. It's tiring. You will make mistakes. And so the pump gives you the bolus wizard. And in the group session, we're going to talk about the bolus wizard also. So the other advantage of the pump is that you can use different ways of giving the bolus, actually 3 different ways of prandial insulin. You can give a normal dose, a square wave dose, it means more protracted dose, or a dual wave dose. What it means is you can give all the doses together. Say you want to eat something and you decide to give 10 units, you can give 10 units. They go in, you don't know how long they will last. Or if you expect that you are going to have a big meal, or you have many plates that are coming one after the other, and it's going to last for a few hours, you can tell the pump to give you these 10 doses over 3-4 hours, whatever you decide. So the dose of insulin will go into the blood in a more protracted time. Or you can tell the pump to give me some insulin right now and the rest. So the 10 doses, you can tell the pump, give me 3 units now and the rest of the 7 units later. So if you can eat pizza that gets absorbed in a more protracted time, you can tell the pump to give you the insulin in a different way. For example, if you eat yogurt and an apple, you can give the pump the dose immediately. If you are going to eat in a Lebanese restaurant and you get this hummus and tabbouleh and fatouh and mixed grills, you can have a more prolonged blood glucose, and you can tell the pump to give you these 10 units over 3-4 hours, because the blood glucose is going to be increasing. Or you can do a dual wave if you eat this kind of thing. Or if you have some patients with gastroparesis, that the food is not absorbed immediately, and then you can have a dual dose, a dual wave dose that you can give some dose immediately and the rest later. So the pump gives you alternatives that you cannot have with a pen. You cannot tell the pen to give you some now. You have to pinch yourself again. So why is the pump better than the needles? Why do people use the pump and they prefer it? Well, not all of them prefer it. Some people prefer the pump, and after they try it, they cannot live without the pump. Some others, they don't want to have the pump. Everybody is different. But the pump has some advantages and some disadvantages. So what are the advantages? First of all, the number of injections. If you have a diabetic type 1 who gives 1 basal and 3 prandial, you do 4 injections a day, times 30 days, that's 120 injections per month. Okay, 1,440 injections per year. With the pump, you are going to have 10 times less of that, only because you change the setting every 3 days, and you never inject anything. You don't pinch yourself anymore in these 3 days. You can have only 12 infusion set changes per month instead of 120, 144 instead of 1,440. So you have less injections. If you ask people if they want to be pinched a lot, I bet most will say, I do not want to be pinched a lot. So with a pump, you have 10 times less injections and pinches compared with the pens. So I don't think many people would like to be pinched a lot. The other thing is that the pump communicates, some pumps communicate automatically with the blood pressure measurement, and so you don't need to type in your blood glucose level, because it automatically goes. This is a special thing with the Medtronic pump, that it automatically takes your measurement, and so with a Bluetooth technology, the measurement from your blood glucose meter goes automatically into the pump. So the pump knows how much your blood glucose is now without you having to type it in, so you avoid the risk of typing in wrong numbers. And then the pump knows every time you measure with this blood glucose meter how much your blood glucose is, and it goes automatically into the wizard that we said before. Now, these are the advantages of the pump. Now, the pump can be combined with a continuous glucose sensor, and so we have what we call the sensor augmented pumps, the SAP, and we can go into real-time measurements. So you can know what your blood glucose is now continuously over 24 hours. So you don't just know a few measurements, you know continuously how much your blood glucose is with these CGM devices. And the pump communicates with the device, and the pump knows continuously how much your blood glucose is, and so it can give you advice of what to do with the insulin continuously. And so the patient knows every moment of the day how much is your blood glucose, and he can decide how much insulin to give continuously over 24 hours. This is a real-time thing that you can control. So making a small parenthesis to talk about this, the CGMs, the continuous glucose monitors, they were introduced into the market in the early 90s. First, it was physician-oriented. It means that the patient would wear the machine and for a few days, at that time 3 days, and then it would give the machine to the physician. He would download it to the computer, and you would see retrospectively what happened 3 days ago. Then in 2005, we had the real-time machines that the patient would see himself what is going on now. He would know immediately and continuously what is going on in his blood, and he would decide based on the information he would get what was going to happen. So the pump communicates with the CGM device, so you have to have two things in your body, one that measures your blood glucose continuously and the other that gives insulin continuously. And these devices communicate and take information from one another. And our hope is to close the system and have the device and the pump communicate automatically without the user need to do anything. So that's the closed loop system and the artificial pancreas that we need to go there. So there are a few companies that have that, like the Medtronic, the Dexcom. Navigator is not available in Greece. We have only these two, Medtronic and the Dexcom. So what happens is the monitor measures the blood continuously, and it gives you a number every 5 minutes. So instead of getting like 4 measurements a day, you get 286 measurements over a day. It has alarms. It can be set that if the blood glucose goes down, it starts giving an alarm and notifying you that your blood glucose is falling, or if it goes up, it gets an alarm again that your blood glucose is going up, and actually it can monitor the rate. If the glucose goes quickly lower, it rings. If it goes quickly higher, it rings. You don't need to go into hypoglycemia to give you the warning, so it can warn you before you go into hypoglycemia. If the blood glucose falls quickly or goes up quickly, you can be notified to do something, and you get these things of information that can be really very annoying for the physician. You get so much information, you don't know what to do with it. We don't have 4 measurements in a day. We have 286 measurements every day for 1 week, for 2 weeks, and we have to decide what to do. So later in the group session, we're going to talk about how, because you have to have some guidance. You read an EKG, you have to know what to do. Now we read these things, what are we going to do, how we're going to read these things. It can be very confusing, so you have to have some guidance how to do it. We take nice curves and nice numbers. Each color is a different day. You have some days that went up, some days that went down. What we're going to do and how we're going to decide how to use them. We get a lot of nice statistics. Only 9% hypoglycemia, 39% were in target, 98%, 48, whatever, so 55% was above the target. So you get a lot of information that you have to decide how to do it. But the advantage of the CGM is that it gives you the real picture. Because say you have this patient that is very good, in our opinion. He checks his blood glucose every time he eats, before he eats, and he injects his insulin. We see in the morning he's quite not bad, 150. Later, for lunch, he's fine. For dinner, he's fine. Before he goes to bed, he's fine. He injects 4 times a day. We think he's fine. But if you do CGM, you see that actually he went into hypoglycemia. We didn't know about that. Then he went very high. He went into hypoglycemia in the evening. We don't see the whole picture because we only take 4 photographs in a day, whereas we have hundreds of things that are going down. And actually with the CGMs, we have seen that it's very simplistic what we think that we know about diabetes, especially in type 1s. We need to think about variation because it's not a stable thing like more in type 2. The log with the sensor gives you a lot of information. The advantage, as I said, is that the sensor has alarms. When the blood glucose goes very high, it can ring an alarm, and you can give an extra injection so you can avoid going that high. You can actually lower it. If it goes lower quickly, it gives you an alarm so you can eat something and don't go into hypoglycemia. And so this is a big advantage that it can tell you continuously over 24 hours how much your blood glucose is changing. Not only how much you have now, but if you are going to go into hypoglycemia or if you are in hypoglycemia, it can ring to you. So if you are sleeping, it can wake you up and do something if you are very high or very low. And so it can try and protect you. So the sensor augmenting pumps, we have quite a few studies now that are helpful. We have seen that they communicate with the pump, and we have better results, less hypoglycemia with the sensor augmented pumps, about 1.2 decrease in A1C without increasing the hypoglycemias, because it gives you information. And we see here a study that before the SAP, you had a lot of variation, at least in the night. You see here that the variation was much lower, and it was on target most of the time. Now, the next pump we have now, after the sensor augmented pump, is what is called the low glucose suspend feature. The pump can automatically switch off when it detects that your blood glucose is low. So if you go into hypoglycemia and you don't do something yourself, the pump automatically will switch off and protect you. So if in the middle of the night you have hypoglycemia, the pump starts ringing, you don't wake up, you don't hear it, you don't know it. If the insulin continues giving you insulin, the pump continues giving you insulin, it might be dangerous. You might go very low. So if the pump sees that you don't do anything, you don't touch the pump for a few minutes, it switches off automatically for 2 hours. So it protects you from going even lower. So this is the low glucose suspend feature. Again, they communicate. If the pump sees that you went very low, it stops giving you insulin so that the glucose does not continue going down. For 2 hours, it stops so you don't go very low. So it protects you when you go into hypoglycemia, the low glucose suspend feature. And we have studies that with the low glucose suspend feature, we had less events of hypoglycemia, less severity of the events, and better values of hypoglycemia. We have a lot of studies about that. Now, the next generation of the pump is the smart pump, the smart guard pump. We have it in Greece now. It's the 640G pump of Medtronic. This does not only protect you from after you have a hypoglycemia, it predicts that you are going to have hypoglycemia, and it tries to avoid this. So it does not ring an alarm when you have the hypoglycemia. It rings the alarm, or it changes automatically the rate before you go into hypoglycemia when the pump predicts that you're going to go into hypoglycemia. How does this happen? If the pump predicts that the rate of going down is very quickly, so if in 20 minutes you go very quickly down, then before you go into hypoglycemia, the glucose suspender would act here, the smart guard acts here, and it decreases the rate, so it does not go down there. It decreases the rate and it goes slower, so you avoid hypoglycemia. So it predicts that you are going to have hypoglycemia before you have it, and it changes automatically the rate so you can avoid hypoglycemia before you have it automatically. So it tries to protect you from having hypoglycemias. With the pump, other features is you can have different basal rates automatically. You can set them, say a day that you don't work and you're at home during the weekend, you can set a different rate. I'm not working, I'm not walking. I will find a different rate, different basal rates. You can set up 8 different rates, and you can just with one type, you can choose the rates, and you can predict. You can also have boluses, different boluses. I'll go a little bit more quickly. What does the screen show? It shows you how much your insulin is. If you have active insulin on board, It shows you a graph of how your blood glucose has been going on, so you can see what is going on. It can show you these arrows, and they show you how quickly your blood glucose is changing. If it's 1 arrow or 2 or 3 arrows, it means that your blood glucose is changing more quickly every time. In the last 20 minutes, it has changed too much, more than 54 milligrams. If you have 3 arrows, 35 to 55, you have 2 arrows, or 18 to 36 if you have 1 arrow. So you can see the change of your blood glucose, not only what you have now, but so if you have now 120, you don't know, am I going up or am I going down? Because if you go down 120, later I might go down to 60. If I'm going up, I'm going to 200. So you don't know. The pump shows you your direction. So it's you know if you're going the low direction or the higher direction. And this can be communicated over the internet. So people now they can communicate it with their physician or with their family. So the mother can be here and his son can be in Thessaloniki, and you can know what the pump shows every time. So you can monitor him, and if he goes into hypoglycemia, you can actually, your mom can see you are in hypo, and you can ask for help or whatever, and your physician can also. This might be too overwhelming now because you might get so much information if you have a lot of patients using it, but it might be helpful. So the dream is to create the artificial pancreas. The concept is that we will have an automatic continuous closed loop system. We will have the monitor that continuously checks your blood glucose. We have it now. Okay, we know that we can measure the blood glucose continuously. We have to have an algorithm that will decide how much insulin you need. And there we have a problem now. We don't have good algorithms yet, at least for the whole day. We have made a lot of progress. And then this will be communicated to the pump, and it will give insulin depending on how much your blood glucose is and how much your needs are that the algorithm will give you. And then this will be fed up in the system, and the system will check if what it did was correct, and it will automatically change without the user need to do anything. So it will be done automatically. Give insulin, see how much your blood glucose is. If it goes up, give more insulin. If it goes down, stop the insulin, like the pancreas, what it does. So that's the dream. Now we are in the situation that 2 centers, one in USA and one in Cambridge, they are working with the algorithms, because that's the basic thing now, is to solve the algorithms. We have the pumps, we have the monitors, we need to solve the algorithms. We need 6 steps to close the loop. We are in the 4th step. The first step was to have the pump and be able to close the loop. I'm going late a little bit. Yeah. The second, I'll finish in 5 minutes, maybe 50. In the hypoglycemia, to predict that it goes down, we have done that. To predict that it goes up and down and switch automatically, we have done. We have now we're in this stage, we have the automated basal hybrid closed loop system. It means that during the night, when the patient sleeps and usually does not eat, the system can monitor the glucose automatically. It can close completely the loop. The system decides how much insulin you are going to have, how much your blood glucose is, and it keeps the blood glucose continuously into a range without the patient interfering. During the day, when the patient needs to eat, he needs to give the information to the system, like how much am I going to eat. The system is not able yet to decide on its own how much carbohydrates are coming and adjust the insulin. So the next step is to have this fully automated insulin closed loop system during the day. It's closed now during the night. The studies show that during the night you can have a very good glucose profile automatically. The patient does not need to do anything. The system monitors the glucose, gives the insulin, and the glucose stays continuously in good range. But during the day, when the patients walk and they eat, the system needs to take information from the patient. The algorithm is not ready yet to do it automatically. And the next step is to have a multi-hormone insulin, multi-hormone closed-loop system. Not only insulin is missing, but glucagon is missing also. So we have now pumps that use both insulin and glucagon to see if we can do things better. The studies show that we have, there are 2 actually models, the model predictive control is one of the algorithms that has been used. That during the night does excellent job. You see the glucose during the night, completely closed system, it stays there, but during the day it doesn't do a good job so far. The second is the modular algorithm that also during the night work well, but during the day they do not work so much. And there are many studies now that have used the systems in everyday life, and we see here between 11 and 7 during the night in home use for 6 weeks. They did very good job, and they did fine, and here in free living environment, not only in closed research centers, but now in the everyday life, they have decreased the hypoglycemia during the night. We have not yet done a good job during the day, and we need to improve it. The other thing is we need better insulins. The insulins we have are not perfect. There are some new insulins coming, like this fast-acting Anspart and another from Lilly, the biochaperone, that show a better pharmacodynamic profile. We hope they might work better with the pumps. And also there are some studies trying to inject the insulin intraperitoneally, so it goes into the portal system. Now, this has been studied for many decades. We have a lot of problems, technical problems, but now they are trying to improve it, and hopefully in the future we'll do it. They are working now with having only one machine. You don't need to have two things in your body. Only one. We know now that it doesn't matter if the two ports are close to one another. The thing that measures the glucose and the thing that gives the insulin, they can be together, so you don't need to pinch yourself twice. So they're working on that also. And as I said, they are already working in the bionic pancreas, that they use both insulin and glucagon. It looks like a bionic person here. The problem with the glucagon is it's not stable, so they're trying to see how they can stabilize it better, and so they can have a pump that gives both insulin and glucagon. So if you go into hypoglycemia, you can have glucagon also, like the normal pancreas does. And there are studies that are working on it. It's still very primitive research, but we hope it will work. And finishing, the flash glucose monitoring system. It's a little bit different than the continuous glucose monitoring. What flash means, it's like a photograph. You measure whenever you want, but it keeps information from the previous. It's the Freestyle Libre system that we already have it in Greece. What it does is you have a sensor that checks your blood glucose continuously, but it doesn't give you information unless you scan it with this machine. So you have the machine, and you use it like this. You scan it, and you take your blood measurement, your blood glucose. It also gives you the previous 8 hours. So every time you scan, you get information how much your blood glucose was during the 8 hours before that. So if you scan 3 times a day, every 8 hours, you get a 24 hours knowledge. It gives you information about how quickly your blood glucose might be changing. And you can also put a lot of information there. If the arrow is going very straight up, it means you're changing more than 2 milligrams per deciliter in a minute. If it's going a little bit diagonal, it's 1 to 2. If it's stable, it means less than 1 to 2. So you give information about how quickly it is changing, and you can get also a lot of information. They are trying to say that this is for people who do a lot of measurements. It doesn't give you the real time and the alarms that the CGM has, but it's very helpful for people who prick their fingers a lot, because you only have to just scan it. You prick it once every 14 days. You never prick it again, and you don't need calibration. With the CGMs, you need to calibrate at least twice a day. So here you get the ambulatory glucose profile. This is something completely new that we're starting to know about this now, and how much it might be helpful. It gives you the pattern of blood glucoses during the previous weeks, and you can see if you are at risk of going into hypoglycemia or hypoglycemia, and what your median is, and you're trying to change various things about your insulin dose or your food. You don't need to calibrate it. It's factory calibrated. Actually, the studies show very good. The MARD, the mean absolute relative difference, is very good. It's like 11%, which is actually extremely good. And they just had this publication last month that people, type 1 people who used the Libre, they had less hypoglycemia because they were checking so many times, 15 times a day, because they were not pricking anymore. So by checking 15 times a day their blood sugar, they were able to make adjustments, and they had much less hypoglycemia when they used this flash technology. Something new that is not in Greece right now, but it's coming. This is a technology that uses ultrasound, electromagnetic, and thermal technology, and you just put a clip in your earlobe, and it measures your blood glucose. It's a company from Israel that has developed it, and they say they have good numbers. We'll see about it. So the flash technology lasts for 14 days, the CGM for 7 days. It does not have alarms, and it does not connect to a pump yet. So this is something that you have to consider it about it. So thanks very much. Sorry,